Uh, Today I'm presenting a case of a 7-year-old girl, resident of NCR region, informant being patient's parents. The, the chief complaints, the patient presented the chief complaints of decreased urine output for 1 week, fever since 1 week, and a tonic-clonic movement of the whole body, one episode. On elaborating origin, duration, and progression, the history dates back. Initially, I would like to specify the antenatal history. She was a booked case of pregnancy, and mother's prenatal checkup was done. She visited an obstetrician, and her antenatal scans were done in early pregnancy. She was informed by the obstetrician that the amount of water around her growing child was in lesser amount than normal, and also she was informed about some stone in her kidneys. The details of the scan were not available to the parents at the moment.
Stone in which kidney? The fetus kidney or the
Mother's. She was not informed about any fetal anomaly. She was not informed about any fetal anomalies in her antenatal scans. There was also a history of one miscarriage at 6 months of gestation previous to this pregnancy. She was born of a consanguineous marriage with a normal full-term vaginal delivery with a birth weight of 3.25 kg. She cried immediately after birth. There was no complaint of respiratory distress or prolonged ICU admission at birth. At around 3 to 4 days of age of the patient, the parents noticed that the child was passing high-colored urine associated with episode of high-grade fever that subsided on its own. Parents also noticed that the patient was crying excessively while passing urine. Although urine stream was normal, but the child had to strain excessively while passing the urine. Mother didn't notice any history of any suprapubic bulging. Mother also noticed that patient was not accepting feeds normally during this episode. There was no complaint of cough, loose motions, or any other complaint with the fever episode. The fever episode subsided on its own. Similar febrile episodes occurred a few times during the first year of life, for which no treatment was done. When at around 13 months of age, patient again developed fever with similar complaints. This time the parents visited a local physician. Her complete checkup was done. This time the parents were told that the child has a creatinine of 1.2 and she was leaking protein in urine. An ultrasound was done at that time that was suggestive of the doctor told the parents that there was an absent right kidney along with a small left kidney. She was referred to AIMS where again an ultrasound was done, and the parents were told that her right kidney was absent and the urine was reverting back to the left kidney. Parents was told that she had an infection of the urine and was treated with oral antibiotics, and the fever episode subsided. The creatinine at this time was found to be around 1.9. Since then, patient had similar episodes twice or thrice a year. Every time they visited a local physician, they were given some oral treatment and the episode subsided. The parents told that the patient had developed the ability to inform regarding the desire to urinate by around 2.5 to 3 years of age. At around 4 years of age, mother noticed that the frequency of micturition during the daytime and nighttime had increased, and also there was complaint of double voiding was noted by the mother. She again visited to AIMS in the follow-up. There she was told that her BP was on the higher side of normal. Here she was started on tablet amlodipine, tablet rhodosis, tablet rivalamar, tablet calcium, tablet calpol, and tablet Sultran, and calcium pouch at the age of 4 years. At around 5 years, Sir,
Are they aware?
this creatinine they didn't tell, sir. Sir, at around 5 years of age, patient again developed a similar febrile episode. Uh, and this time she had associated complaint of severe occipital headache that was associated with generalized tightening of upper limb and lower limb, along with history of altered sensorium, uprolling of eyeballs and clenching of teeth, not associated with tongue bite, but patient was in a state of confusion for a few hours following this event. She was taken to a local hospital where she was given mannitol and antibiotics. There was no associated complaint of ear discharge or any focal neurological deficit. She was admitted here and her creatinine was told to be 3.2. During the course of this hospital stay, parents started noticing that patient has started becoming pale and there is also increasing generalized swelling of the body, initially involving the bilateral lower limbs and gradually progressing to the whole body, along with shortness of breath and a decrease in urine output was noted. The patient's fever was still persistent, so the parents transferred the patient to another hospital where some medication was given to which increased the patient's urine output and IV antibiotics were given. Patient became afebrile, urine output improved, generalized swelling resolved, and patient was discharged with a creatinine of 2.4. Patient continued to have 2 to 3 febrile episodes per year along with inability to gain weight, and the parents noticed that her height and weight were below the peers at all times.
The only child?
No sir, she has an elder brother as well, 14-year-olds.
Okay.
14 years. Sir, till December 22, her creatinine was in the range of 2.6 to 2.8. When in January 2023, she again developed a similar febrile episode, not associated with cough, no complaint of loose motions or vomiting. The fever was associated with a complaint of decrease in urine output, such that initially patient used to go to the washroom 5 to 6 times per day and 2 to 3 times during night. But now patient was going only 1 to 2 times daily. The patient parents also noticed that there was bilateral lower limb swelling initially in the foot and ankle region, gradually extending up to the bilateral knee region. Patient eventually started developing shortness of breath initially on exertion, later on doing daily routine activities like changing clothes. Patient eventually started having no urine output. Patient again developed.
In between these two episodes, was the patient on regular medicine?
So she was taking those medicines.
Was she on antibiotic prophylaxis?
Yes, sir, she has been on antibiotic prophylaxis since 4 years of age. Patient again developed tonic-clonic movement of the whole body, along with clenching of teeth, and patient was in a state of confusion after the episode for a few hours.
This is after 1 year of the previous admission.
No, sir. This is this admission, sir.
This admission.
January 23. Sir. She was admitted and thoroughly evaluated, and this time around her serum creatinine was found to be around 5.9, where she was treated with IV antibiotics and drugs to improve her urine output. Over the course of a few days, her urine output improved, and her generalized swelling was resolved, fever subsided, and serum creatinine came down to 1.9.
This was when?
So this is January 2023. Sir, after this patient was discharged, and she has been following up in the pediatric surgery OPD, and there has been the planning for some surgery, the details of which are not known, sir. Sir,
What creatinine is still 1.9 or 2.
yes, sir, creatinine is not.
And we are planning some surgery.
Yes, sir.
Okay.
Sir, I would like to add to sir some milestone developmental history. Sir, patient did not achieve her patient did not achieve her gross motor and fine motor milestones appropriate for her age. All of them were delayed for her age. Like sitting at, she used to sit with support at around 9 months, and patient was not able to bear the weight of her own body till 4 years of age. Patient had
Like
his
standing के लिए कह रहे हो आप?
hands,
Standing without support.
hands.
वो 4 years तक
4
नहीं
years
है.
तक नहीं. Patient had history of genovalgum and knock knees at around the parents noticed some deformity in the lower limbs at around 2 to 2.5 years of age. They started developing.
Why you say genovalgum? You just say knock knee.
Sir, patient also had a history of dislocation of shoulder 3 to 4 times in the first 2.5 to 3 years of life, even on gentle pull of arms. For which they went to a local doctor who relocated the shoulder back into place with some manual techniques. Although her speech and psychosocial milestones were found to be appropriate for her age, she has had normal interaction with peers and friends at school, but she was always the smallest one in her class in height. Sir, she was vaccinated as per national immunization schedule.
Is she studying which class?
Sir,
She's
she
saying in school, yeah. Which class? And she's doing normal studies or there is
no sir. She is matlab she sir class I don't remember, but sir she is her performance is
is she passing in her exams or whatever? Because it is a mental milestone. You said physical milestones they are delayed. Delayed sitting and standing is at 4 years. They should have been there by 1 year or so. Okay. And recurrent dislocation of shoulders. But what about the mental milestones? Is she going to school that you have told? And is she doing the normal studies or that she is lacking in the studies? This you should have asked. Okay.
sir she has a 14-year-old elder brother who is normal, and regarding personal history, sir, she consumes a mixed diet, sleep and appetite are normal, no history of constipation or incontinence of stool. So
So just give the summary of the history and your clinical diagnosis based on the history.
So, 7-year-old child born of a consanguineous marriage, a full-term normal vaginal delivery with history of oligohydramnios in the antenatal period, with a UTI, with a first UTI at the age of 3 days, with subsequent recurring episodes of UTI over the next 7 years of life. And at the age of 13 months, found to have creatinine of 1.2 and absent right kidney, with reflux in left kidney. At the age of 4 years, developed hypertension and features of chronic kidney disease and started on conservative management for the same, along with multiple episodes of dislocation of shoulder and stunted growth and delayed developmental milestones. At around 5 years of age, had her first seizure episode, followed by worsening of serum creatinine to 3.2, and a similar episode at around 7 years of age, the creatinine of with 5.9, which later came down to 1.9 after.
Okay. So your clinical diagnosis.
Sir,
So vaccination history.
vaccination history, sir, she was vaccinated as per her national immunization schedules.
But what are the vaccinations? Yes.
Sir, initially she received the BCG at birth. Then she had received the Hep5 vaccine, sir, OPV, BCG, hepatitis B vaccine, 3 schedules at 6, 10, 14 weeks, and followed by sir typhoid vaccine at around 9 months of age. She's been for influenza vaccine for 9 months of age.
So your diagnosis. One thing which you had told that ultrasound right kidney absent and left small kidney
जी sir.
with possibly hydronephrosis.
जी sir.
Okay.
So the parents themselves told that they were told by the physician that
You have told in the history. So in summary, you have missed that. So what is your diagnosis?
sir, my provisional diagnosis will be sir acute on CKD, CKD4 with a EGFR of around 20 ml per minute as calculated by the Schwartz formula. The acute factor being recurrent UTI, episodes of UTI, and sir with left single kidney, and sir native kidney disease being tubulointerstitial disease, secondary to reflux nephropathy, secondary to circulatory reflux, probably primary in nature. With sir associated complaint of CKD, MPD, and comorbidity being seizure disorder and hypertension.
हाँ तो इसमें तो इसके causes जैसे एक तो चीज हाईलाइट हुई है कि ड्यूरिंग प्रेगनेंसी व्हेन अल्ट्रासाउंड वाज डन देयर वाज ओलिगोहेड्रोनेमस है ना तो what do you infer from that?
So basically, oligohydramnios suggests there is some kind of deformity in the growing kidney of the fetus.
And what other complications these people develop when they have oligohydramnios?
So oligohydramnios, there is a symptom complex called as Potter's disease, where because of decreased amount of amniotic fluid around the child, there occurs typical facial features along with lung hypoplasia.
So lung hypoplasia is the main problem with that. So it is actually there is anomalies and they are occurring. They can, if there is a agenesis of the kidney, you can have associated other caput abnormalities. So there is some abnormalities like in this patient probably has a reflux. Okay. So diagnosis is pretty clear from, and there are so many episodes of infective episodes of acute and chronic renal dysfunction. Maybe hypertension started in first year, we don't know.
Yes.
How do you assess hypertension in children?
So, in the right arm,
ना तो वहीं पे हम पे ही है मतलब क्या क्राइटेरिया क्या देते हैं उसके Did you measure hypertension in this? अच्छा चलो एग्जामिनेशन तो अभी नहीं बताया तो so there are normograms age related or weight related with which you can say in which percentile the patient is coming and you can say patient is having the last percentile last 5% is the hypertension more than 90%. So then this patient was born, milestones you have described. Again, another thing was these seizures. So patient has significant history of seizures. What could be cause of seizures in this patient?
So what I gather from the parents was that the patient had they were not taking the child to the physician as often as required.
So simply आप आंसर करो ना. Causes of seizure.
So can we
usually आप बताओ क्या है?
Can we uremic?
हाँ, uremic seizures. Second.
So second, it can be due to accelerated hypertension, secondary to CKD.
Okay, maybe accelerated hypertension, malignant hypertension.
He had high grade fever. So febrile.
What else? सबसे कॉमन क्या होता है रीनल फेलियर में? सीजर. कौन से इलेक्ट्रोलाइट?
सोडियम
हाइपोकैल्सियम. सबसे कॉमन तो हाइपोकैल्सियम होता है. हाइपोनेट्रीमिया भी होता है. So these are the could be the causes of seizures.
Without diagnosis, starting right from acute on CKD. First is his syndromic diagnosis, CKD. Okay. CKD, what is the cause? So can put right renal agenesis, or maybe there was an intranatal vesicoureteric reflux that caused small contracted kidney which is not visible on ultrasound, or it may be renal agenesis on the right side. Left side, she has a cycling restricted. So CKD, renal agenesis on the right side with left VUR. Then recurrent UTIs and acute on CKD due to sepsis, UTI sepsis. Then you have got all CKD MBD. She has got renal rickets. Okay, and then development disorders, growth failure, and seizures. और seizures के लिए, as asked from you, febrile, hypertension, and uremic electrolyte disorder. So these you should mention when you are giving a diagnosis. I think it is not going to change after your clinical examination notes. ठीक है, and चलो एनीमिया का तो अभी नहीं बता रहे.
So अब इसमें all this history, what is not clear is like there is a developmental delay in milestone. So what is the cause for that? She was on regular treatment. She was visiting doctors. Why she had developmental delay?
Sir, as told by the parents, so she was the smallest in the class. So
Developmental delay is there. But why? Because creatinine slightly was there high, but that should not be causing developmental delay. If you have caught it at 1 year and you are managing that, then infection were treated. Why there is developmental delay?
So maybe they are not taking treatment properly, or
what are causes of that?
Yes.
Question is indirectly, what are causes of developmental delay in a patient who is having CKD in first less than 10 years of age?
So in patients of pediatric patients with CKD, sir, there is decreased in the growth hormone levels, insulin-like growth factor levels, and
yeah, with all these findings, what will you say? Okay, growth hormone deficiency, is it different? We will come later. Okay. But the things which are very evident, why mineral bone disease has developed in this patient if she was taking treatment properly? That means the treatment was not given. And again, first 1 year of life she had 3 episodes of fever. And I am surprised if she was having UTIs, and how did it go get treated without antibiotics?
You are saying no treatment
No
was given.
treatment was given. It was
It's life
surprising.
threatening.
yes.
So how is it possible?
So first of the parents told sir their first proper visit to doctor and treatment was at 13 months only. Sir. Before that, they were just
So one point will be nutrition. If patient is not eating, there will be no development. So nutritional deficiency because of the illness. She's not eating, she's getting ill again and again. Then you pointed out hormone deficiency, but whether this is the age for that or later on. Then second is like the calcium phosphate balance, vitamin D balance. Because of what? What happens in these patients?
mineral bone disease.
Mineral bone disease, but what is more prominent in that? Acidosis.
Yeah, yes.
The acidosis. There is a persistent acidosis which leads to muscle weakness, muscle atrophy, and delayed milestone and all this. So acidosis, that is part of renal failure. Or if there is some other disorder, like hereditary or some other, like renal rickets, like a hypophosphatemic rickets, vitamin D disorder, some hereditary disorder which has delayed the milestone. Maybe it's just nutritional, maybe it is just acidosis, and maybe there is some concomitant hereditary disorder which is delaying the milestones. ये तो आप रखोगे ना माइंड में कि भाई क्या क्या पॉसिबिलिटीज हैं, तो उस पर भी तो हमें मेहनत करनी है माइलस्टोन्स डेवलपमेंट के लिए.
Actually, these are the things which you should do so that child doesn't develop all these problems. When you catch up a child at 1.5 years, you have to prevent these manifestations, or you have to delay these manifestations. So, what is the definition of CKD in this patient? And how do you say with 1.2 creatinine, what is the normal level of creatinine at age 1? Because you have told 13 months creatinine was 1.2. What is the expected value like?
So at this age, sir, creatinine more than 0.8, sir. Then child.
क्या होते हैं अगर you must have seen the tables, serum creatinine less than 15 days, then 15 days to 1 year, 1 to 5 years, 5 to 12 years and more. क्या levels होते हैं? Okay, 1 year पे 0.3 to 0.5. ठीक है, again, is it enzymatic or Jeffries method? We usually do Jeffries method. Okay. And how do you calculate GFR? You have told GFR less than 20. How do you calculate GFR in a patient?
Sir, in a children,
In child?
sir, there is a formula called Schwartz formula, sir. It is 41. This is 41 into height in meters upon divided by serum creatinine milligram per deciliter.
What is 41? Is it 41 or 0.4? If you multiply 41 by height divided by creatinine 1.2, she will have a supra GFR
Sorry, sir, 4.4.
0.4 and it is K constant.
Yes.
Okay.
Yes.
So again it depends upon what method you are using. If you are using enzymatic, then I think it is 0.4, and if you are doing Jeffries method, then 0.35 or so. Okay. So this is a constant. So other is you divide height by serum creatinine. EGFR calculated divided by creatinine. So other method is this. Okay. So 1.2 creatinine, you say that it was 20 ml or so, less than 20. So what was the stage? So at 13 months, 20 ml GFR, was it, which stage does it come? Stage 4. So are you going to overestimate or underestimate? What is the development of kidney normally? When does it attain a normal GFR? At what age?
At around 1 year, sir.
2 years. So 2 years GFR reaches by adult GFR. So 13 months of age, if you are saying 1.2, it may not be 20 ml. Actually, it may be 30 ml or so if you have calculated like that. Okay? Because at that time, development of kidney is not full. So what you are measuring is a technically lower GFR. So definition of CKD in child, it is different at different age. What is the GFR? How you calculate? So these are the methods. Okay. So why there is one absent kidney and one? So what do you think? Is it bilateral VUR or is it something else? Dysplasias or whatever it is?
So, I think, sir, I think, sir, it is one-sided renal agenesis and associated with the VR in the other kidney.
So maybe possible because if it has gone on for 7 years or so, I would say so. It may be, but kidney right at birth was small. So maybe hypoplasia with VUR. So definitely there is some dysplasia. Okay. So what are the other causes of CKD at this age? Suppose you had not you did not know about what was the kidney size or so, because on history you have told the size. We are not knowing if you had not told. So suppose you didn't know the kidney size. So what are the other differential diagnoses? Patient get it detected at age 1.5 years with CKD.
So most common cause in children is Charcot only, sir. Congenital anomalies. VR is a part of it. And
Other causes of Charcot. What are the other causes?
sir, other causes being sir, ureter duplication, mega ureter.
Would they lead to the renal failure? So Charcot leading to renal failure at age 1. What are the other causes? Anyone? Okay. So dysplasias, hypoplasia, dysplasias, cystic diseases, others. So which kind of cystic diseases?
Multicystic disease.
So that is a dysplastic kidney. Okay. Or
Juvenile nephropathy.
okay. So nephronophthisis. Or
ARP.
oh, yes. So autosomal recessive polycystic kidney disease. Because we are not looking at the ultrasound. So causes of CKD at age 1 or 2 years, these will be the process. And anything else? What are the other causes? Suppose you didn't have the history and 8 years you know patient has got advanced renal disease. What other diseases?
Medullary cystic kidney disease.
Medullary cystic, वो तो nephronophthisis में आ गया.
सेकेंड डेकेड में आएगा.
ठीक. और वो second decade में भी आएंगे. But otherwise, other causes. Okay, we are not going by.
Tuberous sclerosis.
हैं?
Sir, tuberous sclerosis.
इसमें क्या क्या होता है?
Congenital nephropathy.
Congenital nephrotic syndrome. So which kind of congenital nephrotic?
Finish type.
Okay.
Nephrin and finish.
हैं?
Nephrin and potassium type deficiency. Type 1 and type. Autosomal recessive.
टाइप 1 टाइप 2 क्या है?
अच्छा ठीक. Finish. Okay. Any other nephrotic syndrome with some tumors?
Vulnerable in thyroid state.
So Drash syndrome. ठीक. Danny Drash. So okay, I'm not going for all those syndromes, but because Danish Drash syndrome we had seen. So in there you have a nephrotic syndrome with propensity for renal tumors.
So
And what is the other thing in that syndrome? Yes, one more. Male pseudohermaphrodites. Okay.
So even Vagus Williams tumor is also anemia, genitourinary abnormalities are renal dysplasia again.
That is what we are discussing. Drash syndrome is coming in that category. So, and then hereditary nephritis, but not at 1 year of age. 1 year we have discussed. ठीक है, so now suppose because here history is very classical of vesico-ureteric reflux. We are saying recurrent UTIs, double voiding, and bedwetting also.
So now one thing is, how could you manage this reflux? Like, I think nothing has been done for the reflux. So which are the patients? Firstly, what are the methods of management of reflux?
So pertaining to this patient, sir, she was started on.
In general, how do you manage reflux?
So first of all, sir, we can go for continuous antibiotic prophylaxis with the drugs like trimethoprim or codramazole.
Straight away without evacuation.
How you grade the reflux?
So management is first diagnosis, grading, and then. So how do you diagnose reflux?
So first of all, sir, we can do ultrasound examinations, and then, but for grading, sir, we require a MCUG, sir, mutating urothrogram, for diagnosing the grades of reflux, and to look for any scarring, if any, then we can go for a DMSS scans.
How do you grade in MC? How do you grade? Tell the grading.
Sir, grade 1 is, sir, reflux into the ureter only. Grade 2 is reflux into ureter and the pelvic alysis system. Grade 3 is moderate dilatation of the pelvic alysis system with mild tortuosity, sir, in the ureter. Grade 4 is, sir, moderate dilatation of the pelvic alysis system with a moderate degree of tortuosity of the ureter, with fornices, with loss of with blunting of fornices. And in grade 5, sir, there will be a loss of papillary impressions as well, sir, in grade 5.
So now which
fornices are obliterated in grade 3. Okay, and then there is they are totally defaced in grade 4 and grade 5. So grade 3 is ureter, pelvic alysis system with blunting of the fornices, because fornices, they are angles and they become obtuse. And the tortuosity is usually in grade 4 and 5. Okay. But this is again a very subjective, which classification is this?
So this is
International Radiology Study Group. Right? So any other method of diagnosing reflux besides, this is a gold standard, micturating cystourethrogram. Any other thing which you can diagnose? Because बेटे मैनेजमेंट तो तभी आएगी, पहले डायग्नोसिस, ग्रेडिंग ऑफ रिफ्लक्स. So child doesn't cooperate for insertion of the catheter. So any other method?
nuclear
Yes.
क्या कहते हैं उसको?
RC.
कोई भी बता दो क्या आप बता क्या टेस्ट है? आइसोटोप से क्या टेस्ट
आइसोटोप से कैसे करते
मैक 3 क्या है? रिफ्लक्स के लिए क्या करोगे? रिफ्लक्स के लिए
मैक 3 तो आप उसका फंक्शन देखने के लिए कर रहे हो.
एनीबॉडी? नोबडी?
DRCG.
तो क्या होता है DRCG? फुल फॉर्म क्या है? डिजिटल रेडियम न्यूक्लियाइड. नहीं, डिजिटल नहीं, डायरेक्ट. क्यों डायरेक्ट क्या है उसमें? कैसे करते हैं DRCG? सुना आपने कैसे करते हैं? देखा है?
कैसे करते हैं?
कॉन्सेप्ट तो पता होगा, मतलब क्या टेस्ट क्या है, कैसे है कॉन्सेप्ट?
अब डायरेक्ट भी बता दिया आपको. So you inject the material in the bladder directly, suprapubic region, dilated urinary bladder, and then you look for the reflux. और कई बार चाइल्ड थोड़ा ना कोऑपरेट करेगा, वो तो रोएगा, तो तब आपको रिफ्लेक्स मिलेगा. Any other method? Child is cooperative, 4-5 years का हो गया.
Sir, I noticed the position of MCUG.
नहीं, MCUG हो गया, एक सर पूछ रहे हैं कि MCUG भी हो गया, आइसोटोप भी हो गया इसका, DRC, और क्या मतलब?
चलो, what are the shortcomings of DRCOG? उसमें तो आपको रिफ्लेक्स पता लग गया, कुछ और पता लग सकता, कुछ और मिस हो सकता.
So, cannot differentiate some between. It cannot guide us for the any scarring is present or not.
तो स्कारिंग तो आपको MCU में भी नहीं पता लगेगा भाई. लोअर यूरिनरी ट्रैक, यूरेथ्रा कैसी है, कोई पोस्टीरियर यूरेथ्रल वेल्व्स है या नहीं, वो MCU में ही पता लगेगा. सो इसलिए लोअर यूरेथ्रा इट विल नॉट टेल यू अबाउट दैट. एंड अगेन ग्रेडिंग भी इतनी ज्यादा, ग्रेड 1 विल बी मिस्ड, लो माइल्ड ग्रेड VURs दे विल बी मिस्ड.
आइसोटोप स्कैन की आपने फोटो देखी है? इट्स लाइक डॉट्स, so it doesn't delineate the outline very well. It will show there is a reflex, but it cannot delineate or grade it, है ना? Even ultrasound से ना, you can see reflex. The jet of urine you can see it's going back, okay, and there can be dilatation of the ureter at the time of micturating. Then you can observe that dilatation also.
और एक अल्ट्रासाउंड कंट्रास्ट भी होते हैं.
You can do contrast ultrasound that can tell you.
So dual this is ये जो micturating sonography, but you give a contrast so that urine you can see the contrast in the urine, and you can see reflux during sonography. ठीक है, okay. So now you have graded the reflux. So patient has grade 1 or 2 reflux. How will you manage?
Sir, grade 1 to reflux at if it is presenting at initial years of life. Sir, if there is no UTI in the patient, no history of fever, then we can wait, sir, because there is a tendency of the as the child grows, the submucosal tunnel, which is the cause of primary VUR, it grows and it sometimes.
So there is spontaneous recovery or okay. So 1 or 2 may. And when will you give treatment in 1 or 2 reflux?
Sir, if there is a recurrent UTI is there, or there is signs of scarring seen in the kidney in repeated ultrasounds examination, or there is decrease in GFR proteinuria. If the patient is has a deteriorating renal functions. So
then what will you do? You are giving, we are talking about medical treatment, grade 1 or grade 2 reflux. So when do you give medical treatment? Anybody? हाँ जी बताइए.
The current UTI case.
Okay.
Secondary VUR or treatment.
So grade 1 or 2 में अगर UTI है तो तभी करना चाहिए. ठीक है. And when do you give prophylactic antibiotics?
So again, if the patient is having even a single episode of UTI in the first year, we have to give a prophylactic antibiotics.
Or any other situations? Patient is 13 months. Patient cannot talk, cannot tell the symptoms. So this is one of the indications where there is no bowel and bowel training. So जहाँ BBD है, जहाँ पे patient is not able to communicate, वहाँ पे देना चाहिए. If there is there had been even one episode of UTI. Okay. So grade 3 reflux, what will you do?
So in grade 3, grade 4 reflux, I will start with continuous antibiotic prophylaxis.
And grade 5?
So prophylactic antibiotics.
So suppose this patient had grade 5 reflux. Okay. So when would you have advised the surgery?
Sir, surgery will be advised, sir, if there is a breakthrough infection. And
तो हो ही रहे हैं ना इसको तो right from the birth, day 3 of his life, she has been having UTIs.
patient might, if there is risk of developing into reflux nephropathy, sir.
तो उसको वही है.
When you have diagnosed, there is already secret. But suppose otherwise, when is the indication of surgery? So, when do you operate in VUR? Stage 4, stage 5. At what age?
After 5 years of age.
5 years, so too late. So if 2 to 3 years of age patient, this VUR has not regressed, then you have to go for surgery. ठीक है. Earlier the people used to say कि less than 2 years you operate. Okay. So okay, clinical examination.
The patient was conscious, cooperative, thin-built and poorly nourished. Sir, height is 95 centimeter, which is minus 2.95 standard deviation height for age, as per WHO Z scoring. Suggestive of stunted growth. Weight was 12 kg, that is minus 2.02 standard deviation WHO Z scoring.
Just ठीक है.
Mid-arm circumference 10 centimeter. Sir, frontal bossing was present. Pallor was present. No icterus, cyanosis, clubbing, lymphadenopathy. No splaying of wrist bones. Genovalgum deformity. Knock knees were present with intermalleolar distance of 6 centimeters. No signs of recreatic rosary. No Hansen sulcus. And normal apposition of clavicle with the costochondrial junction. So, regarding back and spine examinations, no sacral defect present, no sacral tuft of hair, no dimpling in the sacrococcygeal area. Now, sir, vitals, sir.
Any high arch palate, crowding of teeth. You told almost all the findings of rickets were high arch palate and crowding of teeth. They are also okay. Okay. You are talking about some spinal deformities, meningocele, that you have told. Okay.
So, vitals at pulse was 90 per minute, BP was normovolemic, normal in rhythm character, no radiolateral 80 per minute. BP was 140 by 90 in the right arm supine position. And so,
because again, secondary reflux, if there is some abnormalities, meningomyelocele, there is no history now, otherwise there will be a history of. Suppose you had examined this child at 13 months of age, then you will think of all these things. Okay. So coming to the blood pressure, what Dr. Ravi Bansal had asked you.
So, sir, I told you more than 95 percentile will be.
Did you check BP or not?
Sir, I checked, sir, it was 140 by 90. Sir.
बहुत ज़्यादा है. ऑन मेडिकेशन एम्लोडिपिन दे रहे थे, उसके बाद भी ये.
So she has been on amlodipine since 4 years of age.
So with amlodipine 140 BP, ठीक है. Even in adult we will say कि it is resistant hypertension.
How does this reflux cause renal damage and hypertension?
Sir, reflux, sir, it leads to sir reflux nephropathy. That is, there due to the reflux, due to water hammer effect, sir, there occurs renal scarring at the polar regions of the kidney, which eventually lead to sir nephron damage, and sir due to the maladaptive. Because of maladaptation, there occurs hyperfiltration injury and leading to eventually proteinuria, decreasing GFR and hypertension.
तो हो गया ये sterile reflux, है ना? Intrarenal sterile reflux. और क्या है second mechanism?
Sir, there is a concept of Big Bang as well, sir. That one first episode of UTI causes the maximum damage to the kidney and
Infective
Plus
reflux.
infection and this pressure. So why it is there in poles?
so because sir, the structure of the kidney, sir, that sir, there are some papilla called complex papilla, compound papilla, which are present only at the upper and lower poles, and they have a concavity. They have concave shapes. So
They are called refluxing papilla. Why there is a reflux?
sir, the mechanism for primary reflux is sir, in insufficient length of the submucosal tunnel of the ureter into the bladder. So as per the Paquin's rule, sir, there has to be a ratio of 6:1 in the
5:1.
5:1.
I think 5:1.
Of the length and the diameter of the ureter, sir. If it is less than that, the reason being, sir, if there is a lateral and proximal attachment of the ureter to the bladder, so the submucosal tunnel is shorter in length and not able to prevent the.
So okay, short ये जो है इंट्रा ये जो है वेसिकल यूरेटर. Okay, any other thing?
Sir,
Any abnormalities of orifices?
yes, sir. Sir, normal orifices, sir. Conical normal ureteral orifice is conical in shape, sir. If there is other structure of the orifice like a stadium shape or a golf hole shape or a
golf hole orifice.
horseshoe shape, that will be.
And if there is an associated outflow tract, some outflow tract, then there will be a lot of reflux. Another point I want to highlight is that it is the basically RAS associated fibrosis which occurs in the kidney, which causes a scarring. So RAS activation and the medicines used for blood pressure control, probably inhibiting RAS system will be better to prevent fibrosis.
बाकी है कि decreased nephron and hyperfiltration. So that is the secondary mechanism of renal failure. Okay. So आगे clinical examination. Any other positive thing?
Sir,
So systemic examination no.
sir, no contributing findings.
So no change in diagnosis.
Yes, sir.
So suppose now this patient was there with you at age 4. Okay? So what would you have done? Because at that time she has developed hypertension. The renal failure had worsened 2.8 grade acute on CKD. So what would you have done?
Sir, at 4 years of age, if this patient had presented to me, sir, I would have gone for a surgical.
See the upper कोई investigation so we how would you have managed?
Sir,
थियरी हो गई है, क्लिनिकल बताइए।
sir, sir, I would have initially.
So कैसे अप्रोच करोगे इस पेशेंट?
Sir, initially I'll sir, check for kidney function test and
वो तो हो गया, ठीक है।
sir, then we'll go for sir radiographic ultrasound examination and DNS
वो
scan.
तो हो गया कंफर्मेशन ऑफ वेसिकोयूरेटरी। अदर थिंग्स ना, अगर वो मैनेज होती जाती है, पेशेंट जल्दी इतनी जल्दी ESRD में ना जाता, बोन डिजीज ना होते, ठीक है, तो वो क्या क्या देखोगे? सो आपने बोला MBD, तो MBD के पैरामीटर्स क्या है?
Sir, I will sir, check for serum calcium levels, serum phosphate, vitamin D, sir, and IPTH levels.
Yes.
And sir,
Metabolic profile, anemia profile, and then her nutrition, assessment of nutrition,
एसिडोसिस देखो,
acidosis देखो,
सबसे पहले तो एसिडोसिस देखो, इसमें पोटेशियम और एसिड दो चीजों को कंट्रोल करो।
patient को recurrent UTIs हो रहे, so you would have gone, one kidney is already gone, so other I think if one had gone for a surgical treatment, but once you have not evaluated, you don't. You were talking about that score 5:1 or 6:1. कैसे देखते हो? You have heard about UDR? I think he was talking about UDR. क्या होता है UDR? जो आप तुम वो बता रहे हो ना कि diameter of the ureter, तो you are telling theoretical and that is correct. पर कैसे देखते हो आप? कैसे कैलकुलेट करते हो? So what you do is on MCU, you जो है largest diameter of the ureter between lower border of L1 and upper border of L3. So that length divided by the largest diameter. So that is the ratio UDR. And it is actually suggestive, or it will predict कि patient will improve after the surgery, derefluxic surgery. ठीक? So what you were talking about, I think it was that. So अब इसमें क्या करोगे? Suppose patient was with you, उसको UTI हुआ था, creatinine उसका 2.8 था, you have controlled the infection, creatinine 1.9. ठीक? क्या करते हैं?
so first of
और
all,
उसको grade 5 reflux था, kidney protein, already scar तो हो गया. So what is the advantage of doing surgery? Somebody will say कि patient kidney has already shrunken. So what is the necessity of doing the surgery? We have feather.
sir, as per the Reiberg study, sir, there
अब studies नहीं. पहले ये है कि conceptual क्या है?
sir, it
दो ही चीजें होती हैं कि infection prevention and ये जो है protect the GFR. Already scarring तो काफी हो गई. Maybe कि anti-reflux surgery is not helpful in protecting GFR, but here it will definitely prevent from the infections. Infections prevent होंगे, one of the factors causing renal failure you are avoiding. So that is the reason for doing surgery, to prevent infections. ठीक?
so there may or may not be effect on the CKD progression.
बिल्कुल, but infection. So by controlling infection, because you have seen 2.8, it came down to 1.9. So if you control the infection, you can take the kidney for a longer time. So that is the purpose of it. And do you know of what are the surgical techniques?
Yes, sir. One surgery is a Cohen surgery, sir. That is slightly difficult to perform, but that is basically to increase the submucosal length of the ureter. And the more commonly performed one is the ladder header surgery. It is more commonly performed of ureteric reimplantation surgery. Open surgical ureteric reimplantation is the preferred approach, is the best, is considered to be the best one. But having known the comorbidities of surgeries nowadays, laparoscopic and even endoscopic and even robotic surgery, ureteric reimplantation are done.
So, which are the best?
So open surgical is considered the best.
ठीक है, क्या करते हैं? कौन से रूप से होते हैं? You are saying a lot of names. I don't know of, but what are the basic fundamentals? So it is intravesical. Open the blood. That is the best. 95 to 99% success rates. ठीक. और दूसरा है कि एक्स्ट्रा वेसिकल. Suppose there was grade 3 or grade 4 reflux. Patient doesn't want to go for surgery. क्या कर सकते हैं? Any surgical intervention?
So reflux procedure can be done. So injection of dextranomor and hyaluronase have been also been tried, sir. But the drawback is, sir, we need to repeat it again, sir.
ठीक है, उसके सक्सेस रेट्स जो अराउंड 70% है डिफ्लक्स पे. और एनीथिंग एल्स? So if there is any other secondary cause, posterior urethral valves, which are more common in the males, ठीक है, but females में हो सकते हैं. Fulguration. Because and at times you can go for circumcision also, because incidence of reflux, secondary reflux. So that is one of the in circumcised people chances of reflux are less. Okay. But now coming to primary question of Dr. Bansal, why she went or she developed renal failure or other renal bone disease, malnutrition, delayed milestones. So how would you have prevented? Or suppose patient has come to you at 2 years of age, how would you prevent all these things?
Sir, first of all, sir, as sir told, sir, we'll correct the acidosis part, sir. We'll give a soda vodka tablets and to control the acidosis part and prevent bone demineralization. Sir, we'll keep a track on serum calcium and phosphate levels. Sir. We'll give her phosphate binders for high phosphate levels. Maybe calcium-based phosphate binders may be required if the patient is on a low calcium. And sir, then sir, we'll try to keep the BP in check, sir.
Vitamin D supplementation.
Vitamin D.
So there are two things which are, when kidney starts getting damaged, two things happen. One is vitamin D deficiency. Second is acidosis. They are subclinical, even sub-lab, even lab cannot detect. They are happening because they are getting compensated. So two things are important, vitamin D and acidosis. After that is the calcium phosphate balance, electrolytes, potassium. Suppose she has a tubulopathy. So if you see growth problems, either it is a nutritional, or it's a renal tubular acidosis, or it is the chronic renal failure related acidosis or developmental problem, or the one which is like hereditary hypophosphatemic sort of rickets or things. So these are the various groups. Your patient is in one of these groups. So first one is you first treat the acidosis electrolyte and give vitamin D and see how patient responds to that. And hypophosphatemia rickets or hereditary syndrome may not be there, I think, because the profile clinical examination, you said the rickets and all features are not so prominent. So maybe it is not a hypophosphatemic rickets. And then RTA also, because there's a renal failure developing, there's a reflux. So RTA also probably is not the acidosis will be because of the renal failure rather than tubular disorders. So this is mainly management will be on these lines.
We try to keep some IPTH between 3 to 9 times of normal.
You would see.
Boy,
What did you
in
say?
child,
What did you say? I couldn't.
3 to 9 times
Between
of the normal limit of PTH level. भाई यही तो बच्चों में डिफरेंस है यार. चलो है अब आ जाओ सर. What is the preferred level of PTH in a child of age of 6 years age? So pre-dialysis and dialysis. ये adult वाला नहीं है. Adult जो 3 to 9 times on dialysis, यहाँ तो totally different. You will try to keep PTH level as near normal in a child less than 2 years. Then up to 6 years, you will keep it around 100 times. Only if she develops ESRD and she is on dialysis, then you will keep it around 3 times. So यहाँ बच्चों में difference है. नहीं तो उनकी bones तो बिल्कुल खराब हो जाएगी. So what is the earliest abnormality in renal boat disease? अभी बताया ना डॉक्टर रवि ने कि earliest they may not be even biochemically visible नहीं होंगे, and that is why you don't treat. Calcium, phosphorus normal होंगे, but stage तो काफी है. So what is the earliest abnormality? So सबसे पहली चीज है phosphorus retention. और hyperphosphatemia भी अभी बहुत लेट डेवलप करे. So पहला है सब क्लिनिकल और सब ये जो है लैब में भी नहीं आएंगे. So phosphorus retention हुई. फिर क्या हुआ?
So phosphorus retention initially will
क्या बताओ. हाँ क्या हुआ फिर?
Initially, sir, parathyroid hormone will try to compensate for the and will try to improve.
थोड़ी बहुत बात की बात है. So phosphate retention increase in FGF23. और FGF23 increase होता तो क्या होगा?
So basically, a phosphotonin sir causes excretion of phosphorus from the body.
बताओ यार. ये तो stages of yes vitamin D deficiency क्यों होगी? Yes, alpha 1 hydroxylase inhibit करेगा. So phosphate retention FGF23 it will inhibit alpha hydroxylase. So vitamin D deficiency.
Even before sir FGF23 sir chloride levels will decrease.
Clotho और वो they come simultaneously. You are right. So vitamin D deficiency, then what will happen?
So vitamin D deficiency will eventually lead to some low calcium and low calcium.
Then your PTH will start rising. और यहाँ पे आपका ये जो phosphorus rise करेगा, phosphorus rise करेगा, hypocalcemia होगा because of hyperphosphatemia and vitamin D deficiency, then PTH will rise. So this is the sequence. That is why if you just don't look at all these things, or if it is not there in your mind, you will not treat. So start treatment right when the biochemical abnormalities are not there.
How will you give vitamin D to this patient? How much dose?
कौन सा दोगे विटामिन डी? अल्फा हाइड्रोक्सिलेज तो नहीं है, तो क्या
सर कैल्शियम ट्रायल
या अल्फा कैल्शियम? ठीक है, तो क्या डोज दोगे? अब ये बड़ी इम्पोर्टेंट है, बच्चों में क्या दोगे? ये भी है, एज वाइज देनी है आपको। चलो ये पढ़ो, ठीक है।
और बाइकार्बोनेट कैसे रिप्लेस करोगे, एसिडोसिस कैसे करेक्ट करोगे ना, ये चीजें पता होनी चाहिए। एक्चुअली एसिडोसिस करेक्शन एंड इलेक्ट्रोलाइट मैनेजमेंट इतना कर दो ना किसी बच्चे में सीकेडी में, आपको काफी साल अच्छे निकलेगा, ग्रोथ फेज भी मिलेगा,
ग्रोथ फेज हो जाएगी,
ग्रोथ फेज मिलेगा। अगर इसको 1 ईयर पे आपने एसिडोसिस, इलेक्ट्रोलाइट्स और विटामिन डी मैनेज कर दिया होता ना, इसको ग्रोथ मिलती।
so fluid, electrolytes and acidosis. What is the reason of poor nutrition in this patient? What are the factors? Growth hormone नहीं है इस स्टेज पे अभी। ग्रोथ स्पर्ट कब होती है?
female child at around 8 to 9 to 10 years.
So अभी ये छोटी
प्यूबर्टी के टाइम की बात है,
पुबर्टी की टाइम की बात है।
10 इयर्स के बाद की बात है।
पर यहाँ पे यही है एसिडोसिस, पुअर एपिटाइट, लॉस ऑफ टेस्ट, नॉशिया, वॉमिटिंग। बिकॉज अगर पेशेंट को एसिडोसिस रहेगा, यूरिनिया रहेगा, तो ये चीजें हैं, दे विल लीड टू पुअर न्यूट्रिशन। सो इफ यू करेक्ट दीज थिंग्स, ठीक है, एंड देन करेक्शन ऑफ एनीमिया, bone disease would have been prevented if calcium phosphorus had been kept properly and acidosis were corrected properly. Okay. So what is renal osteodystrophy?
Sir,
This patient has got CKD-MPD.
sir,
So the last question and
so the spectrum of events of mostly of high bone turnover disease.
so anybody else? So why renal osteodystrophy की जगह पे MPD आया? So what is the rationale? And
Part of this spectrum of CKD, which involves skeletal cups, which can be diagnosed.
so there is biochemical, skeletal and biopsy. ठीक है, so renal osteodystrophy is a radiological. So what are the types of renal osteodystrophy? Anish?
Sir, low turnover, high turnover, sir. Sir, osteoporosis, osteomalacia. Sir, low turnover is dynamic bone disease.
So high turnover bone disease,
Low turnover,
osteitis fibrosus.
cystic.
Okay. Low turnover,
Dynamic bone disease.
ADAL. Which is the most common?
Sir, most common is high turnover, sir.
दोनों को mix करो. So it is a mixed kind which is more common. And then comes osteomalacia. ठीक है. So what is the difference between osteomalacia and adynamic bone disease?
Like on mineralization or decrease in osteomalacia.
So osteomalacia is lack of mineralization. Osteoid forms, while adynamic bone disease both are osteoblastic activity, that is good. Where is it common? What are the reasons for this?
Old age child takes vitamin D supplementation or the other way.
So over enthusiastic. So hydrogenic causes ज़्यादा. Diabetics may on dialysis, on CAPD. So these are common. But again, if you without rationale, if you give vitamin D without monitoring, then also you will lead on to. That is the reason you want to keep PTH 3 to 5 times, even 3 to 9 times we likhte hain. So that is the reason to prevent adynamic pregnancy. So last question. So when will you talk to the family for transplantation?
So,
And suppose patient family agrees for transplantation, what will you first assess and what precautions which you will take?
sir, the most important thing will be sir bladder assessment of this patient. So, if there is some problem.
Okay, bas enumerate.
So,
सो ये ट्रांसप्लांट कब करोगे? अभी सपोज आप इसका GFR जो है 15 है, तो उसको बोलोगे या नहीं? What is preemptive transplant?
the transplant is
So in children we should go for a preemptive transplant. Why? So that growth and ये जो है is skeletal as well as mental as well as ये जो pubertal growth they all ये जो है improve if transplant is done at this age 6 to 8 years of age. एक बार
dialysis is difficult to manage patient in dialysis.
or more prolonged you go for dialysis, less are the chances of survival. So you will offer them a preemptive transplant. And that is why I asked you, if family says you go for, patient को अगर recurrent UTIs हो रहे हैं and breakthrough infections है, so what can you do?
sir, then
Maybe you might have to go for a nephrectomy. ठीक, सो ये चीजें हैं आपको. चलो गुड, थैंक यू सो मच. सो विजन जो है ना अपनी ब्रॉड रखो. अभी तो और कॉजेज ही नहीं हमने, क्योंकि दिस पेशेंट वाज क्लियर कट VUR लेफ्ट साइड में, और इट कुड बी एजेनेसिस, और इफ देयर इज इंट्रा in utero VUR of a high grade, kidney may have been gone. He is so much small, you might not have been able to see. So it could be very well a case of bilateral VUR. But dysplasias and hereditary nephritis, not in this patient. When somebody asks you causes of CKD in children, then hereditary nephritis. Or last time I said, good.